Well, hello everyone. Welcome back to another Women's Health Diagnosis webinar series. And we are into part 2, and today we're going to be discussing endometriosis. And my name is Heaton, and I am the Women's Health Clinical Liaison. So today we're going to have a general overview of what endometriosis is. We're going to look at the brief history and go over some statistics. Then we're going to look at the pathophysiology, the etiology, the diagnosis, signs and symptoms, and some treatment options, both conventional and integrative. So, what is endometriosis? Textbook says it is a systemic inflammatory disease with hormonal and immunological disturbances, sometimes leading to tissue similar to the inside lining of the uterus growing in other areas of the body, including the ovaries, the bladder, intestines, and lungs. So, in endometriosis, the cells that form the endometrium grow outside of the uterus, and it most often occurs on or around reproductive organs, in the pelvis or abdomen. So, just to go through a brief history of endometriosis, in the 1860s, Karl von Rokitansky, who is a German gynecologist, actually provided one of the first documented descriptions of endometriosis in medical literature. And then in 1920s, John Sampson, an American gynecologist, actually proposed the theory of retrograde menstruation as the potential cause. In the 1980s, there were diagnostic advancements using laparoscopy, which is a valuable tool for the diagnosis and staging of endometriosis. In the 1990s, researchers actually identified the molecular and genetic factors underlying endometriosis. And that, of course, led to advancements in the understanding of the pathophysiology of the condition. In the 2000s, there were therapeutic developments where new treatment options were available, including hormonal therapies, NSAIDs, surgical interventions, which were huge improvements in the management of endometriosis. In 2010s, there was increased awareness, campaigns, and patient advocacy efforts, which bring the attention to the impact of endometriosis on a person's quality of life. And this was when we had a higher focus on research and healthcare support. So, endometrial tissue can grow anywhere, including the eyes. The tissue thickens, breaks down, and bleeds each month. Implants are the areas of tissue growing outside of the uterus, and these implants actually produce their own estrogen through aromatization, and they also produce their own estrogen even if the patient is prescribed medications to lower the estrogen, causing the surrounding areas to grow. These implants can also migrate to the spinal cord, which can cause excruciating lower back pain. These implants can also grow in the muscle wall of the uterus, causing bleeding into the uterine muscle during the menstrual cycle, causing pain and irritation. So, endometriosis affects roughly 10% of reproductive age women and girls globally. So, 1 in 10 women of reproductive age will get it. And the percentage goes up in certain populations, such as infertility, it's up to 50%. And women with pelvic pain is up to 70%. Okay, so let's go over the pathophysiology. So, endometriosis is not well understood, and it's probably multifactorial in origin. So, the most widely embraced theory involves the retrograde menstruation. So, this is when endometrial cells traverse or they travel to other areas of the body during menstruation. When the endometrium is sloughed off during menstruation, it's believed that cells escape and they go to other locations, including the surrounding areas of the pelvis. Some get into the fallopian tubes, and some cells get to the ovaries and other places in the body, which we'll go over shortly. So this shows the pathophysiology of how endometriosis comes about. So under the influence of hormones, the endometrial tissue is, of course, located outside of the uterus. It thickens and then it breaks down and bleeds each month. And this blood apparently becomes trapped, it forms cysts, and it irritates the surrounding tissue. It can create scar tissue and adhesions, which ultimately lead to infertility. And over here, with the irritation in the surrounding tissues, it creates a lot of pain. And here are some common sites of endometriosis. The ovary is the most common site, and that's in 30 to 40% of all cases. But as you can see here, it can affect the peritoneum, the appendix, the bladder, rectovaginal septum, the colon. So it can affect a lot of other areas surrounding the reproductive organs. So sites, specifically the pelvic, where you have the ovary, the cul-de-sac, uterosacrals, posterior surface of the uterus, the rectovaginal septum, and then the extrapelvic sites involve the intestines, vaginal, the GI, the lungs, and the urinary tract. So the hallmarks of endometriosis: it's estrogen dependent. These endometriotic lesions are very estrogen sensitive. And of course, estrogen promotes the growth, survival, and inflammatory response of the endometrial tissue outside of the uterus. And usually in endometriosis, you're going to find an imbalance between estrogen and progesterone signaling, which you'll find more often than not estrogen dominance, contributing to lesion development and progression. And then you will also find inflammation, and the presence of ectopic endometrial tissue triggers a chronic inflammatory response in the pelvic cavity. And of course, this inflammatory environment is associated with increased levels of pro-inflammatory cytokines, chemokines, immune cell infiltration, leading to tissue damage, fibrosis, and pain. And the dysregulated immune response contributes to the development and persistence of endometriotic lesions. So there are three types of endometriosis. You have the superficial peritoneal endometriosis, ovarian, and deep infiltrating endometriosis. The first one, the superficial peritoneal endometriosis, is the least severe, and that's where the endometrial tissue adjoins to the thin membranes, which lines the pelvis, peritoneum, and the abdomen. And usually this cannot be palpated on clinical exam, so it's difficult to visualize on imaging, and diagnosis is by laparoscopy. Ovarian endometriosis, also known as ovarian endometrioma, is located on the antimesenteric surface of the ovary and causes adhesion to the posterior peritoneum. And the cyst wall is white or yellow, and it's filled with chocolate-colored fluid, so hence the name chocolate cysts. And when it's large, it can be detected on a pelvic exam. And the third type is deep infiltrating endometriosis, or it's also known as posterior pelvic endometriosis. And it's a severe form of endometriosis located in the rectovaginal space. And it can involve the uterosacral ligaments, cervix, the bowel, or ureters. And it can be felt on pelvic and per rectal exam as tender induration and nodularity, and it can be visualized on imaging. Let's get into causes. Okay, so in the medical literature, the cause of endometriosis is unknown, and some theorize the stage is set for endometriosis at birth when the baby girl experiences a sudden withdrawal of the mother's hormones. And endometriosis symptoms can begin in puberty when her estrogen levels rise and she begins menstruating. And there's no known way to prevent endometriosis, and there are many underlying risk factors associated with this disease. So there is no unifying theory regarding the origin of endometriosis, but there are several theories that have been proposed and researched. But the most common and the most recognized theory is Sampson's theory of retrograde menstruation. And this, of course, assumes that Every time a woman has a period, cells from the endometrium inside the uterus, of course, shed and come out with the menstrual flow. And part of the flow moves backwards through the fallopian tubes and reaches the pelvis and the abdomen. So this may sound strange, but 9 out of 10 women experience retrograde menstruation. And it does not only occur during the menstrual period, but it also can occur between periods during the menstrual cycle. And shortly before ovulation, the uterus generates suction whereby endometrial cells are drawn into the fallopian tubes. And some of the endometrial cells reach the abdominal cavity. They manage to implant into the pelvic and abdominal organs, and they continue to grow, generating the ectopic endometrial implants. And there's also coelomic metaplasia, vascular and lymphatic spread, and alter immunosurveillance theories. So there's no single theory that can account for the location of endometriosis in all cases. And this is just a nice chart showing the various sites that are affected by each theory. So there is no single universally accepted theory that explains all cases. And this is most likely because endometriosis does not have a single disease pathway. It's reflected by many different clinical manifestations of the disease, the different areas of the body affected by it, the different levels of severity, and the different symptoms experienced by many women. The complexity of the condition and its many different presentations suggest that many different factors may play a part. Common to all theories is that estrogen is required for the endometriotic lesions to grow and expand. And that is why endometriosis is hardly ever seen in young girls before they start menstruating, and no lesions are seen in women who have reached menopause. So, some risk factors that contribute to endometriosis include family history, endometriosis in first degree relatives, like a mother or a sister who have had it. The risk of getting it is 7 times more with a first degree relative. Starting your period at an early age, like before age 11, if you're estrogen dominant, so that's where you have hormonal imbalances there. Immune dysfunction, it could just be due to a lack of immune surveillance in the pelvic area. Patients with endometriosis have suppressed natural killer cell activity in their peritoneal fluid. And usually they have higher levels of IgG and IgM. And they have reduced clearance of endometrial cells due to a decreased natural killer cell activity or decreased macrophage activity. Diet that's low in fruit and vegetables, diets high in fat or too much red meat, menstrual cycles that occur more frequently than 28 days, and menstrual bleeding that lasts more than 7 days. Other risk factors include a sedentary lifestyle, exposure to environmental estrogens, endocrine disruptors, your parabens, your phthalates, your PCBs, your bisphenol A's, pesticides, plastics, household cleaners, detergents, dioxins, formaldehyde. And patients may have a genetic predisposition where they have a genetic variant in their single nucleotide polymorphism, which increases their risk of developing the disease when exposed to any of these toxins listed. And it is known that endometriosis can run in families, and therefore the genetic factors play a role and how it develops in some women, but not in others. It occurs more commonly in family groups, including twin studies. Other risk factors, poor estrogen metabolism, and microbiome imbalance. More risk factors, history of repeated uterine and vaginal infections, intense and chronic stress. There's also a genetic involvement. There's a deficient expression of 17-beta hydroxysteroid dehydrogenase type 2, which impairs the inactivation of both estrone and estradiol, which is a cause of increased estrogens in endometriosis. and inflammation. And since endometriosis is an inflammatory disorder, bleeding during the menstrual cycle causes inflammation, which triggers cytokines, chemokines, growth factors, and protective factors to migrate to the area. And of course, the inflammation leads to fibrosis, scarring, adhesions, and pain. Endometriosis is also an independent risk factor for epithelial ovarian cancer, and the risk of malignant transformation of ovarian endometriosis was estimated to be about 2.5%. Okay, on to diagnosis. So we have to check for clues of endometriosis, such as the pelvic exam, and that's just to check for unusual changes. It could be cysts on the reproductive organs, painful spots, irregular growth, like nodules and scars behind the uterus. A lot of times, small areas of endometriosis can't be felt unless a cyst has formed. Ultrasound, such as the transvaginal ultrasound, a standard ultrasound won't confirm whether you have endometriosis, but it can find cysts linked with the condition called endometriomas. MRI, it helps with surgical planning since it gives detailed information about the location and the size of endometrial growth. And laparoscopy. Laparoscopy is the gold standard for diagnosis, but recent guidelines advocate a non-surgical diagnosis based on symptoms and findings on physical examination and imaging. And endometriosis is challenging to diagnose since imaging technology may not capture the tissue depending on where it is. So laparoscopy and biopsy, which can be invasive, are required for conclusive diagnosis. So basically, with this procedure, a camera is inserted through the belly button where you can look into the pelvis and the ovaries and the fallopian tubes to see if there's any endometrial implants, and a biopsy can be performed. And of course, tissues can be looked at for pathological diagnosis. And of course, the aims are for detection, biopsy of lesions, staging disease, and the concomitant laparoscopic surgical treatment. And here's the typical appearance of minimal endometriosis on the uterosacral ligaments. And here is the peritoneal erosions and adhesions. So this is more severe endometriosis. And here is the most used and best known system that was developed by the American Society of Reproductive Medicine. And it's a classification system that is divided into 4 stages or grades according to the number of lesions and the depth of infiltration. And the classification also uses a point system to try to quantify endometriotic lesions. So a score of 15 or less indicates minimal or mild disease, and a score of 16 or higher can indicate moderate to severe disease. So this point system has its limitations, and it doesn't always accurately match the patient's symptoms or fertility status. And here at stage 1, you'll see few superficial implants. And then, of course, there's more deeper implants in stage 2. And then there are many more deep implants and presence of filmy adhesions in stage 3. And of course, there's a lot of deep implants and many dense adhesions in the severe stage 4. Now we go into signs and symptoms. So some common signs and symptoms: pelvic pain, pain during sexual intercourse, painful periods, cramps that are 1 to 2 weeks around menstruation, heavy menstrual bleeding or bleeding between periods, the discomfort with bowel movements, lower back pain that can occur at any time during the menstrual cycle, and of course, infertility. So with pain, the clinical presentation is the classical triad, which is dysmenorrhea, dyspareunia, and deep-seated pelvic pain. And it starts before the onset of menses, continues through the menstrual period. It is cyclical. The deep dyspareunia is due to the stretching of the tissues that are involved during intercourse. There's also fixed retroverted uterus or involvement of the uterosacral and rectovaginal septum. And of course, there's dysuria. which is very painful, voiding, urgency, frequency. And then there's abnormal bleeding. It may include premenstrual spotting, also polymenorrhea or frequent menstrual bleeding, where menstrual cycles are shorter than 21 days, and menometrorrhagia, which is prolonged or excessive uterine bleeding that occurs irregularly and more frequently than normal. Infertility. So, approximately a third of women with infertility have endometriosis. And among women with endometriosis, about 40% are infertile. And in the pathogenesis of infertility, it's dependent on the stage of the disease. So in the early stage, it's hypothesized that it is secondary to an inflammatory response that impairs various aspects of conception. Whereas in later stages of the disease, there's distorted pelvic anatomy and adhesions that contribute to impaired fertilization. And this is just a visualization of some of the symptoms that are experienced in endometriosis. Exhaustion or fatigue is another one that's pretty big, just because if you're in a lot of pain, you're going to be tired. And then there's gastrointestinal disorders, abdominal pain. Okay, let's get to treatment. So, endometriosis clinically manifests either as pelvic pain or infertility, and often treating and managing the pain component or the fertility component can be technically challenging, and it can often be a tug of war. So if we treat the pain, often we suppress the hormones and stop fertility. And if we support fertility goals, then hormones can flare and aggravate the pain. So, this is why treatment should be really tailored to the goals of the individual, as well as looking at the underlying triggers in order to support the body holistically to better manage the condition for an optimal quality of life. We're going to start out with conventional therapy. So, the conventional approach to endometriosis is usually based on managing the symptoms. And allopathic treatment options generally include, for pain management, your nonsteroidal anti-inflammatories. For mild pelvic pain and for more severe pain, opioids are often used. Other medications that are used conventionally, the conventional approach is to shut down the hormone system. So if you get rid of ovarian function, you won't have periods, which also means you won't produce progesterone or estrogen, which are essential for the whole body. And because of the dependence of endometriosis on the women's cyclic production of menstrual cycle hormones, provides the basis for medical therapy. So, combined oral contraceptives are generally used to suppress ovarian function, and your continuous non cyclical forms of oral contraceptives basically helps to avoid menstruation and associated pain. But there is a high incidence of side effects, and the risk of clotting limits their prolonged use. And of course, you also have oral progestogens, which are synthetic progesterone, and these have anti-estrogenic effects. And the continuous use causes endometrial atrophy. And medroxyprogesterone has proven efficacy in pain suppression in both the oral and the injectable depot preps. And Mirena has also been shown to reduce endometriosis associated pain as well. And then you have danazol, which is the synthetic derivative of ethinyl testosterone. It's got anti-estrogenic and anti-progestational properties. It is the most extensively studied agent for endometriosis, but it fell out of favor due to the higher incidence of adverse effects like hirsutism, weight gain, depression, muscle cramps, vaginal dryness, and atrophy of breast and vaginal epithelium. And many of these drugs are often used short term, since shutting down hormones in a young reproductive aged woman can have serious consequences on the cardiovascular system, on bones, on all tissues in the body, including the brain. Then you have aromatase inhibitors, and of course, aromatase is the key enzyme for ovarian estrogen biosynthesis. So it catalyzes the conversion of androstenedione and testosterone produced in the ovarian theca cells to estrone and estradiol in the ovarian granulosa cells. And evidence does show that endometriotic lesions express aromatase and it can synthesize their own estradiol. So the most common aromatase inhibitors used are letrozole or Pharmara. Usual dose is 2.5 milligrams, and it's usually in combination with a progestin like norethindrone, 2.5 milligrams. You also have an anastrozole or a Arimidex. Usual dose is 1 milligrams. So aromatase inhibitors with a progestin is successful in decreasing pain and reducing visible endometriosis in patients who haven't responded or tolerated other treatments. All right, now we're into the gonadotropin releasing hormone analogs, and they're administered continuously to downregulate, suppress the pituitary gonadotropins. It causes atrophy of the endometrial tissue, and it can be given in doses of 10 to 20 milligrams IV twice a day. And prolonged therapy greater than 6 months causes estrogen deficiency, of course, with menopausal symptoms like hot flashes, vaginal dryness, and osteoporosis. And the efficacy is limited to pain suppression. The most common analogs are your Zoladex or Goserelin or Lupron Depot or leuprolide acetate. So here we have the gonadotropin releasing hormone antagonists. They're a newer addition to the medications that are indicated for endometriosis associated pains. They're orally active, non-peptide antagonists of the gonadotropin releasing hormone receptors on the pituitary gland. And these antagonists block the secretion of pituitary gonadotropins within hours, leading to a drop in ovarian production of all of your vital hormones, estrogen, progesterone, and testosterone. And as a result, you may end up with symptoms of estrogen deficiency, such as hot flashes, but you may see elevated serum lipids and greater decreases from baseline in bone mineral density. The advantages of the antagonists: they're oral administration versus depot injections. They don't cause an initial flare-up of gonadotropin secretions like the agonists do, which could lead to the exacerbation of endometriosis symptoms in the first 1 or 2 weeks of use. And shortly after discontinuing the oral antagonists, the recovery of the menstrual cycle occurs with estrogen levels returning to their normal premenopausal levels. And the oral antagonists have been identified as effective second-line treatment of endometriosis-associated pain. So we have elagolix or Oralisa at 150 milligrams a day or 200 milligrams twice a day, and Relugolix, which is Orgovix, 40 milligrams a day. There is a new combination therapy released in August of 2022. FDA had approved the Relugolix, estradiol, and norethindrone combination, or Myfembree, for moderate to severe endometriosis-associated pain. And in both studies of the Spirit 1 and Spirit 2, 75% of women who used the once daily Relugolix combination actually had a significant reduction in dysmenorrhea compared with the 27 and 30% of women in the placebo group. And then the combination therapy also reduced non-menstrual pelvic pain in 59% and 66% of women, compared with 40% and 43% in the placebo group. And also in both studies, the combination showed decreases in dyspareunia and opioid use compared to placebo, and more women treated with the combination therapy were opioid free at week 24 compared with those in the placebo group. And surgery. And surgical efforts are basically aimed at the removal of the endometrial implants and the correction of the anatomic distortions. And the implants can be ablated using either laser energy or electrosurgical techniques. Usually this is reserved for women who have completed their family or for women with severely disabling pain that's unresponsive to more conservative approaches. So in addition to medications and surgery, an integrative approach looks at really the underlying factors contributing to endometriosis development and symptoms. So, with an integrative approach, we look at supporting the pain, balancing hormones, reducing the inflammation due to oxidative stress, and also supporting a healthy immune response by correcting gut imbalances. So, some integrative interventions using food as medicine, eating more plant based diet, fish, while eliminating gluten can reduce inflammation. Adding flax seeds and cruciferous vegetables help to, of course, detoxify excess estrogen. Also, some immune enhancing properties of turmeric, ginger, garlic, mushrooms, and other foods, can be very, very beneficial. Reduce exposures to endocrine disruptors. Of course, these toxins tend to shift hormone balance in the body, like toxins like BPA, phthalates that are found in plastics and clothing, cosmetics. They act like estrogen. They're like estrogen mimickers in the body, and so they can exacerbate symptoms. Optimize healthy daily habits like exercise, sleep, stress management. And of course, regular exercise helps to increase blood flow. And also consider adding hip circles like belly dancing to improve circulation in the pelvis. So, some dietary influences. There are foods that exacerbate endometriosis, like coffee, red meat, trans fats, and alcohol, while eliminating gluten, eating more cruciferous vegetables and fruits like broccoli, Brussels sprouts, cauliflower, cabbage, and kale, with the omega-3s like flaxseed, walnut, fish, and avocados, and foods that are high in fiber all improve endometriosis. We also want to prioritize your gut health. Regular bowel movements are essential. It's very important for estrogen detox. So if a patient comes in and they're saying they're not having bowel movements but once a week, that's a sure sign right there that they've got a gut issue. Consider a comprehensive stool test, of course, to assess the microbiome and, of course, identify possible infections that can be causing inflammation. Physical approaches like pelvic floor physical therapy, abdominal massage, acupuncture, and all of these are supportive options for pain management and improving abdominal circulation. Then there's also solar therapy, which is a new laser treatment that uses light energy for treating chronic pelvic pain in women. And of course, using supplements to target the various symptoms in endometriosis is another integrative intervention. So to target pain, we can use pycnogenol, which is an extract of pine bark. And at 30 milligrams twice daily for 48 weeks, this study actually showed a 33% reduction in pain, including severe pain. And while the pain reduction was not as strong as hormonal treatment, it persisted without relapse, unlike the medication group. So 30 milligrams twice a day for a year and continue as needed. Then we have ginger root powder at 500 milligrams 2 to 4 times a day has been shown to reduce pain equal to the effects of ibuprofen. And it's so good for the gut lining as well. Take in the few days before and during menses at the higher dose for the best pain relief. And then we have cannabis. So cannabis, women across the world have been using cannabis in various forms to treat endometriosis and period pain. The CBD is the non-psychoactive component of the cannabis plant. And of course, THC has that psychoactive component, and both reduce endometrial pain symptoms. They are a safer alternative to opioids, more so the CBD than the THC. Dosing in the product brand is unique to each person. Targeting estrogen dominance and balance. So we have progesterone, which modifies the action of estradiol, which decreases the amount of time estrogen stays on the receptor sites. And progesterone cream that is made from Mexican wild yam can slow or prevent the overgrowth of the endometrium in people with endometriosis. It is thought to do so by blocking the formation of new blood vessels in the endometrium, and it slows or stops the invasion of endometrial tissues outside of the uterus. It is important to note that over-the-counter progesterone creams can be ineffective, and also it could create imbalance just because it's not customized to a person's individual need. And so bioidentical hormones that are compounded in compounding pharmacies are much better because of the micronization of the molecules so that it can actually penetrate the skin much better for bioavailability. And also, we can customize the dose to fit the individual need. Ashwagandha, Withania somnifera. It is commonly used for stress and anxiety. It is a medicinal plant. It is in a category called adaptogenic herbs. And studies have found that women with advanced endometriosis had significantly higher levels of cortisol, which is our stress hormone. And this actually dampens that stress response. And it also has estrogen balancing effects due to the polyphenols in ashwagandha. And usually it's used as 500 milligrams to 600 milligrams for stress and anxiety. DIM is short for diindolyl methane, and it is a metabolite of indole 3 carbamol. And it is a compound that is made from cruciferous vegetables like broccoli, cauliflower, and other cruciferous vegetables. It helps to improve estrogen metabolism, and starting dose is 200 milligrams. Vitex, which is chasteberry, and it balances hormones by raising progesterone levels, balancing out the estrogen dominance that occurs in endometriosis, since it is an estrogen dependent disease. Dosing could be anywhere from 20 to 40 milligrams a day. Calcium D-glucarate is also linked to the body's detoxification process, particularly useful for women with endometriosis due to its effect on estrogen. So it eliminates excess estrogen from the body by binding it in the digestive tract before it is reabsorbed. And of course, excess estrogen contributes to the growth of these endometrial tissue. Reducing the levels can help to manage these symptoms. And dandelion root, or Pterosacum officinale, it helps to detox the liver and gallbladder for estrogen detox. Some natural aromatase inhibitors that are used. So high inflammation in the body can upregulate aromatase, increasing estrogen production in the pelvis and in other organs. Estrogen normally is a hormone of healing and nurturing, but it really doesn't know that endometriosis is something abnormal. So it thinks it's damaged tissue. So it nurtures it, creating new blood vessels to feed it. So, of course, this facilitates the cells implanting in the peritoneal surfaces and on the surface of these pelvic and abdominal organs. So it can be quite a mess. So we can use chrysin, which is a potent flavonoid that is found in plants like passion flower and honey. We have apigenin, which is also a flavonoid in plants like celery and parsley, basil. It's a powerful aromatase inhibitor. Genistein is also an isoflavone that is found in soybeans and tofu. It's an estrogen antagonist and anti-inflammatory. We also have resveratrol, which is found in red wine, usually like the French Cabernet and the California Pinot Noir. Grapeseed extract contains biologically active compounds known as proanthocyanidins, and research suggests that these compounds are a powerful inhibitor of aromatase activity, which can help with endosymptoms like pain. We also have green tea, or ECGC, which is the active component in green tea that is a major anti-inflammatory and natural aromatase inhibitor. And then you have foods like fiber, lignans from flax seeds, genistein and diazin from soy. Now, these are isoflavones that are found in soybeans that modulate the oxidative stress and potent inhibitors of estrone and estradiol sulfation. So it's important in the metabolism and detoxification of estrogens. And so the genistein and diazin from the soy, it needs to be non-GMO. Okay, supplements that target inflammation include N-acetylcysteine, which is a precursor to glutathione, which is one of the most important detoxifiers naturally produced in our bodies. 600 milligrams twice a day. Then we have curcumin at 400 to 600 milligrams TID. Curcumin is in turmeric, which is it has a yellow color to it, so it can be staining. Resveratrol, which is an amazing inflammatory product. Quercetin is a natural flavonoid that decreases the proliferation of endometriosis cells, and you can use 500 milligrams to 1500 milligrams daily. Omega fatty acids not only reduce inflammation, but they also inhibit the activity of prostaglandins, which can reduce pain associated with endometrial lesions. And that is given 2 to 3 grams a day of combined EPA and DHA. Melatonin. It is a neurohormone synthesized and released at night by the pineal gland. It has anti-inflammatory, analgesic, and antioxidant properties, and studies have shown that melatonin can prevent and treat endometriosis by reducing the size and weight of the endometriotic lesions. And you can begin with 1 to 3 milligrams per day, building up to 10 to 20 milligrams daily, based off of patient tolerance. Okay, so supplements targeting the immune system. We have the alpha lipoic acid, which is a naturally occurring antioxidant in the human body. Accumulating evidence suggests that alpha lipoic acid might have immunomodulatory effects on both the adaptive and the innate immune systems, and it helps to modulate pro-inflammatory cytokines like TNF alpha and IL-8 to reduce the stroma cell proliferation. And that's 200 milligrams twice a day. Your zinc, it's powerful antioxidant and anti-inflammatory mineral. It acts to quell inflammation, scavenge free radicals, support the immune system, heal wounds, and supports fertility. An antioxidant clinically, zinc supplementation alone can actually reduce inflammation markers and oxidative stress, which are basically two factors that endometriosis is renowned for. Doses 15 milligrams to 50 milligrams a day. Just keep in mind of the copper zinc ratio, which is actually 15 to 1, with zinc to copper. And vitamin D, it's an anti-inflammatory, anti-proliferative, antioxidative, and it has immunomodulatory effects. So you can do 2,000 international units per day or 60,000 international units in a single dose. Seaweed, it stimulates T cell production, and usually your standard dose is 5 grams per day. Then we also have to target the gut. The link between endometriosis and gut health may be due to inflammation, and it can be due to the action of inflammation in the peritoneal area, which contributes to the production of inflammatory chemicals, which are the cytokines. And these chemicals travel to the digestive tract, play a role in altering gut function. So this can be due to their ability to suppress gastric acid and alter gut motility. These changes alter the intestinal environment, making it less hospitable for beneficial organisms and allowing for the overgrowth of potential pathogenic organisms. And so this link between the role of the inflammation that is seen in endometriosis and how this impacts gut function, leading to gut dysbiosis. People with endometriosis often have an imbalance of microorganisms, which probiotics and prebiotics may help correct. And the evidence isn't conclusive, but studies suggest that those with endometriosis may have lower levels of certain strains of bacteria within the gut microbiome. This means a probiotic supplement containing Lactobacillus acidophilus could be helpful, together with the prebiotic, which is basically food for the probiotic. They help break down estrogen also in the GI tract, which helps with the detoxification process, reducing that accumulation of estrogen, creating that estrogen dominance in endometriosis. It's causing a lot of the pain and infertility. So the take-home message, endometriosis has a significant effect on women's emotional and physical health. Misdiagnosis and underdiagnosis of the disease are usually due to limitations in the diagnostic tools, as well as the recognition of symptoms, since the symptoms kind of mirror other conditions that can be easily be missed. Awareness of the risk factors and potential causes, the pathogenesis, can also help identify patients with this condition. We still have a long way to go with learning and research and figuring out how this disease process comes about. We don't fully understand the etiology, but now that there's more awareness, I do believe that there will be more research and that maybe perhaps down the road there will be a better understanding of the disease process. And as a result, we could have better therapeutic management of the disease. And here are your references. More references. Thank you for joining us today, and please connect with us. We are a national network of 503A and 503B compounding pharmacies, providing innovative and quality pharmacy preparations and services through industry best patient care and solutions for our customers and healthcare professionals. We're here to help you help your patients with programs like Consult RX, which is a nationwide VIP service for clinical consulting with our functional medicine and anti-aging board-certified team of clinical pharmacists and practitioners bringing a combined 50-plus years of experience to provide the highest level of service possible. And please join us for another informative webinar coming soon.